Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 573 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, TSE is an 85-year-old woman and resident of a long-term care facility, abbreviated as LTCF. She is 5 feet 2 inches tall and weighs 102 pounds, with a serum creatinine of 1.6 milligrams per deciliter. She is admitted to the hospital for chest pain and shortness of breath, and to rule out myocardial infarction, abbreviated as MI. Her physician is concerned about over-sedation with narcotics and prescribes ketorolac 30 mg IV every 6 hours. She has a history of severe heart failure and angina for which she takes lisinopril 10 mg daily, furosemide 40 mg daily, aspirin 81 mg daily, and isosorbide mononitrate 30 mg daily. The lisinopril dosage is increased to 20 mg daily, and the furosemide dosage is increased to 40 mg twice daily. Her blood pressure is 110 systolic 66 diastolic, and her urine output has been from 20 to 30 milliliters per hour for 4 hours since ketorolac was initiated. My first question to you reads, what risk factors are present in TSE for drug-induced renal problems? The correct response is, TSE has a number of risk factors for the development of drug-induced acute renal failure. Angiotensin-converting enzyme inhibitors are indicated for heart failure management and improve renal function by increasing cardiac output. However, they can diminish efferent arterial glomerular capillary filtration pressure and precipitate acute renal failure in predisposed patients. The use of ketorolac is another risk factor. A 13% incidence of azotemia has been reported in long-term care facility residents started on a short course of non-steroidal anti-inflammatory drug treatment. A low serum sodium concentration, high-dose diuretics, diabetes, severe heart failure i.e., New York Heart Association Class 4, use of a long-acting angiotensin-converting enzyme inhibitor, and concurrent non-steroidal anti-inflammatory drug use are all risk factors for drug-induced acute renal failure. Elderly patients may be particularly susceptible, owing to the renal changes of aging described earlier. Patients with these risk factors should be monitored closely when an angiotensin-converting enzyme inhibitor is initiated and when the dosage of an angiotensin-converting enzyme inhibitor is increased. Renal prostaglandins, such as PGE2 or PGI2, increase or help maintain renal blood flow when renal function is compromised by intrinsic renal disease, heart failure, liver disease with ascites, or hypertension. Therefore, the use of a prostaglandin inhibitor such as ketorolac places TSE at an increased risk for acute renal failure. The ketorolac dose is excessive for TSE based on the maximum recommended dose of 60 mg per day for elderly patients. The first case reads, TMC is a 73-year-old woman who comes to a brown bag session at the local senior center. She reports recently feeling sluggish and dizzy. She lives at home alone on a modest, fixed retirement income. TMC's chronic medical problems include coronary artery disease, abbreviated as CAD, heart failure, hypertension, diabetes, and hyperlipidemia. She states that different specialists prescribe her a lot of medications, but she does not know their names. She admits to skipping her medications periodically when she does not feel well. TMC usually maintains an active social life, visiting her friends and attending the local seniors' luncheons. She is interested in natural medicines, and self-medicates with non-prescription medications and herbal remedies that her friends also take. Because of the recent weakness, however, she has not gone out as much. Review of her brown bag reveals the following items: Glyburide 2.5 mg twice daily, hydrochlorothiazide 25 mg daily, atenolol 50 mg daily, niacin 500 mg 3 times a day, acetyl salicylic acid 325 mg as needed, digoxin 0.25 mg daily, isosorbate dinitrate, abbreviated as ISDN, 20 mg 4 times a day, nitroglycerin, abbreviated as NTG, 0.4 mg sublingual as needed, captopril 25 mg 3 times a day, furosemide 40 mg twice daily, acetaminophen 500 mg as needed, verapamil 60 mg 4 times a day, multivitamins with minerals, calcium carbonate 500 mg 3 times a day, ibuprofen 200 mg as needed, and pioglitazone 30 mg daily. She also drinks a glass of red wine with dinner. So my first question to you reads, what initial steps are necessary for safe and effective management of TMC's drug therapy? The correct response is, like many ambulatory older patients who are being treated for multiple chronic medical conditions, TMC is at high risk for drug-induced problems secondary to non-adherence, medication errors, prescribing from multiple providers, self-medicating, and polypharmacy. She is representative of more than 9 million older adults who live at home alone. The isolated community-dwelling older patient is typically female 75 years of age or older, has multiple medical issues, and takes multiple medications. With rising life expectancy, the increased complexity of managing multiple medical conditions has put non-hospitalized elderly individuals at higher risk of experiencing adverse drug reactions and for adverse drug-related admissions. Another group of older individuals at higher risk of having adverse drug reactions is those who were recently discharged from the hospital. The post-discharge period is often a time of confusion, and elderly patients may have difficulty coping and sorting out new versus replacement or duplicate drugs. TMC presents to the multidisciplinary geriatric care team on the advice of pharmacists at the brown bag session. During the intake interview, she admits to selective adherence with many medications based on how they make her feel and their costs. Her wine intake with dinner is 8 to 12 ounces most days of the week. She also has not taken her furosemide and potassium supplement because she feels that they are contributing to her sluggishness and dizziness. TMC's medical history and physical examination are as follows. 73-year-old white woman, a height of 5 feet 6 inches, a weight of 189 pounds. Vital signs are as follows: blood pressure, 168 systolic, 82 diastolic, heart rate, 54 beats per minute, temperature, 98.7 degrees Fahrenheit, and respiratory rate, 18 breaths per minute. Pertinent laboratory values are as follows. Serum creatinine, 1.5 mg per deciliter. Blood urea nitrogen, 35 mg per deciliter. Sodium, 153 milliequivalents per liter. Potassium, 3.1 milliequivalents per liter. Magnesium, 1.5 milliequivalents per liter. Glucose, 250 mg per deciliter. Glycosylated hemoglobin of 9.5%. Total cholesterol, 259 mg per deciliter. Low-density lipoprotein, 140 mg per deciliter. High-density lipoprotein, 40 mg per deciliter. Triglycerides, 200 mg per deciliter. Urine dipstick 2+ protein. And digoxin level, 1.5 nanograms per milliliter. Electrocardiogram showed sinus bradycardia with an old anterior myocardial infarction. Echocardiogram showed an ejection fraction, EF, of 25%. Her problem list includes new onset sluggishness and fainting, chest pain and shortness of breath on exertion, 3+ pitting edema bilaterally, NYHA class 2 to 3 heart failure, hypertension, type 2 diabetes mellitus, obesity, excessive alcohol intake, coronary artery disease, and hyperlipidemia. So my next question to you reads: what factors may be contributing to TMC's feeling of sluggishness and dizziness? TMC needs a primary care provider to coordinate her medical care and to evaluate the new onset sluggishness and dizziness. She should also be advised to establish a client-patient relationship at a specific pharmacy for all her medications to be on one profile for continuous assessment. Furthermore, TMC should be counseled to discontinue alcohol, which can interact with several of her current medications and worsen her conditions. Finally, assessment of the risk for medication-related problems, abbreviated as MRPs, is highly recommended. TMC's sluggishness and dizziness are most likely caused by her low heart rate, somewhat dehydrated state, and multiple medications that have the potential for producing weakness. Specifically, digoxin 0.25 mg daily is considered a high dose. Patients over age 70 should be limited to 0.125 mg daily as initial therapy to limit the development of toxicities from reduced renal clearance. A level of 1.5 nanograms per milliliter is excessive because the therapeutic range is from 0.5 to 0.9 nanogram per milliliter for HF. Therefore, the digoxin dose should be lowered to 0.125 mg daily. If heart failure is controlled, one can try discontinuing digoxin to evaluate the continued necessity of this agent. Finally, atenolol and verapamil can both lower the heart rate and contribute further to the sluggishness. Switching atenolol to an extended-release beta blocker indicated for heart failure may help. Verapamil can be discontinued because it may not have benefits for TMC other than for hypertension and may contribute to a worsening of her heart failure. The next question reads: What is appropriate management for TMC's stage of heart failure? On the basis of TMC's history of an old myocardial infarction evidencing structural heart disease, her low ejection fraction, and the presence of fluid retention symptoms, TMC is in stage C heart failure based upon the American College of Cardiology, American Heart Association classification scheme. Heart failure is a common cause of morbidity and mortality in older patients. The standard therapy for heart failure with reduced ejection fraction typically consists of angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers, and beta blockers. In symptomatic patients, diuretics may be used for symptomatic relief, and an aldosterone antagonist for its morbidity and mortality benefits. In selected patients, digoxin or hydralazine isosorbate may also be appropriate to reduce morbidity and mortality, as well as to prevent hospitalizations. The recommended therapy for TMC includes an angiotensin-converting enzyme inhibitor, or angiotensin II receptor blocker, a beta blocker, aldosterone antagonist, and diuretic for symptomatic relief. Routine use of multiple medications in the treatment of heart failure with coexisting medical conditions makes close monitoring of drug therapy essential. Concurrent behavior modification with weight loss and salt restriction will also allow better control of heart failure. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 574.